Hello folks, in this video we're going to talk about when to switch anti-VEGF agents in the treatment of neovascular age-related macular degeneration. Usually, anti-VEGF agents are very efficient in the treatment of macular neovascularization secondary to AMD, with control of the anatomic features and visual improvement in a large subset of patients. Fortunately, we have 5 agents available for treatment of neovascular age-related macular degeneration: bevacizumab, ranibizumab, aflibercept, brolucizumab, and recently faricimab. In general, indication for any retreatment to treat again is when one sees activity of the disease by detection of intraretinal or subretinal fluid. However, in some circumstances that we're going to discuss in this video, the retina specialist may need or consider to change the medication to achieve better outcomes. Let's get started. Which are the 2 usual regimens for treatment of wet AMD? Usually patients start with 3 monthly dose, which is the loading dose. Afterwards, there are several variations of regimens, but the 2 most popular are TAE, which stands for Treat and Extend, or Pro-Renata, PRN. In the treatment and extend, the retina specialist treats monthly until the disease becomes inactive, dry, and then the injector starts to extend the injection, always treating until it reaches 3 or 4 months interval between each injection. Once activity is detected in the treat and extend regimen, the patient should be returned to the monthly injections. In the PRN, patients must come every month and be treated when signs of activity are detected. Let's keep moving. Before the specialist considers to change medication or retreat, one must always keep in mind about the mimicking disorders like central serous choroidal retinopathy, acquired vitelliform disease, or other retinal tubulations which may simulate intraretinal fluid. Which are the options before switching medicine? First, one may consider decreasing the interval between injections, because sometimes patients are not resistant, but the duration of the efficacy of the medication is less than 4 weeks. And if one treats every 2 weeks, which is off-label but very reasonable, control of the disease may be achieved. The second option is failure of treatment or functional loss. Sometimes there is an RPE tear or macular atrophy or subretinal fibrosis with a very poor vision, and then one may consider to stop injections. And I'm gonna put a link in the description. We have a video in this channel here, when to stop. Third thing one must keep in mind, there are recent studies that have shown that increasing the dose, the volume of the medication, for example, aflibercept from 2 to 8 milligrams, may induce better outcomes. And now we go to the switching itself. Switching is justified when there's evidence of poor or inadequate response, either in morphology or function, with the treat and extend or PRN approach. Based on the VIEW studies and the clinical trials of ranibizumab, about 20 to 30% of the patients are not responders to aflibercept or ranibizumab. In the treat and extend approach, Usually when there is activity and the injector or the specialist cannot extend for a reasonable interval, one may consider to switch. But how does switch work? Which are the hypotheses that we can change medicine and have a better outcomes? First, switching may overcome tachyphylaxis. Tachyphylaxis may occur when there is overexpression of the receptors or an increase in circulating VEGF in patients with wet AMD. Second, there are some pharmacological differences between anti-VEGF agents. They are very similar, but some block other variations of the VEGF family cytokine, or they have different binding affinity, and those differences may induce a different response. And third, each person, each individual may have fine differences in the VEGF form or size or chemistry that some medicines may work better for one or the other. So we have the three hypotheses why switching may be reasonable: tachyphylaxis, individual genetic difference, and the differences in the pharmacokinetics or pharmacodynamics of the drug itself. Which agents to choose and the outcomes? As a rule, one may start with the off-label agent like Avastin. But if the patient is being treated with the off-label drug, the first thing to do once you go through all those criteria and you decide to switch is to change to an on-label medicine like ranibizumab or aflibercept. Usually that switching leads to very good anatomical and functional results. If the patient is being treated with ranibizumab or aflibercept, switching to the off-label Avastin may be performed, but some studies have shown not so good results. Switching from ranibizumab to aflibercept may lead to anatomical improvement, but functional changes are not so evident based on a few studies. And there is one more option before switching, which is adding PDT for cases of polypoidal choroidal vasculopathy. So we have reviewed key features of the treatment, very objectively, of the treatment of wet AMD. Switching is a reasonable approach and may be performed in some patients which are failing to the current treat and extend or PRN approach, as long as there is no mimicking disorders, reduction in the interval does not lead to any improvement, or a change in the volume or dose of the anti-VEGF is not successful. I hope you like this objective and focused review in this short video. See you in the next time.